Good afternoon, and thank you for attending our webinar today. Our topic today is integrating healthcare and public health to improve HIV early detection and control. Our speakers today are Deborah Porterfield and Christine Bevc. Dr. Porterfield is Senior Research Public Health Analyst at RTI International, has training in health services research, public health, internal medicine, and preventive medicine, and has 6 years of public health practical experience at the North Carolina Division of Public Health. Her work in public health systems and services research focuses mainly on performance measurement in state and local health departments related to cancer and diabetes. And she's had projects for the Centers for Disease Control and Prevention. An additional area of focus she has is integrating public health and primary care, and has past project work in that regards for the Agency for Healthcare Research and Quality and PCORI. Dr. Bevc is a research public health analyst at RTI International. Her work in public health systems and services research is focused on applying her expertise in social networks and social science research methods to better understand and improve interorganizational relationships and collaboration. Her research focuses broadly on organizational behavior, environment, and society, as well as disasters. She has past work for CDC and the National Science Foundation. So would you all like to take over?
Great, thank you so much. Well, good afternoon, everyone. My name is Deborah Porterfield. On behalf of our team, we'd like to welcome you to this discussion of our project, Integrating to Improve, Integration between Healthcare and Public Health to Improve HIV Early Detection and Control. We'd like to thank our funders, the Robert Wood Johnson Foundation, and also the support of the Systems for Action National Coordinating Center for convening this webinar. Our project team is composed of academic-based investigators and practice-based researchers from RTI, UNC, University of Florida, and the Florida Department of Health. We hope we've brought a nice balance of research expertise in areas such as integration between healthcare and public health, social network analysis, and public health systems and services research, as well as the practice insight to accomplish the aims of this study. We'd like to acknowledge the assistance of our key practice partners in 4 HIV regional service areas in Florida. The study took part in these 4 areas, and in each area we had a key partner who is either the county health department or a regional health planning council. We recruited these partners with the assistance of the Florida PHSSR Practice-Based Research Network. The critical role played by each partner included helping the research team learn about the unique features of each network, acting as advocates for the project in their communities, supporting implementation of our web-based survey, and assisting in obtaining organizational outcome data from the Ryan White Services reports. We'd also like to thank the Florida Department of Health, HIV and AIDS section for their support of the project and assistance in its development. So the clinical and public health problem that this project addresses is suboptimal engagement in HIV care for persons with HIV/AIDS. This diagram is one depiction of what has been termed the spectrum of care or the continuum of care for persons with HIV/AIDS. Though it does not show the complexity and the back and forth of movement of persons along the spectrum, which is from the far left, unaware of HIV infection, through screening and awareness, receiving some HIV care, and to the far right, fully engaged in HIV care, and even more to the right but not depicted, viral suppression. This has been an extremely useful diagram to engage many stakeholders around outcomes of interest. An early estimate of the outcomes, for example, and a statistic that got a lot of attention was a study from 2010, and the estimate of 20% of persons with HIV being unaware of their diagnosis. So this next figure shows some national estimates with slightly more recent data, showing the drop-off at each of the stages of HIV care, leading to, on the far right, this final estimate of only about 30% of persons with HIV achieving viral suppression. So an underlying issue which can explain some of these gaps in care is the fact that there's not a single system of care for persons with HIV, but rather a fragmented system or perhaps many overlapping systems. A specific concern is that persons screened in public health or community settings must be linked to clinical care. Effective patient care is then highly dependent upon organizational connections and a well-functioning system. But linkage is not the only challenge. Gaps in testing all persons at risk, identifying HIV-positive persons at an early stage, and ensuring continuous care also represent failures of this macro system to limit the impact of HIV infection on individuals. Relatively siloed federal funding may very well contribute to this fragmentation of the system. In addition to foundations, the major funders the major organizations that support awareness and testing as the Center for Disease Control and Prevention, whereas the funders of HIV care, the major funders are Medicaid and the Health Resources Services Administration. Furthermore, there appears to be an evidence gap between current policy recommendations and current research on HIV systems of care. There's early information about organizational best practices in linkage or in retention and care, but no research on what or how organizations can work together to achieve a system to successfully enable linkage to care and continuous care. Briefly, we developed a project logic model which attempted to capture the continuum of care as well as, in the blue boxes, the influences on patient flow through the continuum of care as well as on the delivery of appropriate services. So we have them depicted here as individual, family, community, and policy context, as well as in the upper left corner, the main box of interest to this project, health system characteristics. These include both characteristics of the individual organizations as well as the characteristics of the networks or the system. So our research aims, the first is to examine how public health, primary care, and community organizations work together as a system to identify, link to care, and provide continuous care for HIV patients, using a social network analysis framework and methods to carry out this and the other research aims. Our second goal is to determine organizational and system characteristics associated with the delivery of continuous care. And finally, our third goal, to develop resources to improve HIV systems of care based on study findings. So a very high-level view of our project milestones and methods. We first conducted in-person planning meetings in each of the 4 areas, and our key community partners helped us to convene the meetings as well as identify the stakeholder organizations to invite. Subsequently, we conducted 3 to 5 discussions with key stakeholders in each area to determine size and characteristics of each network. These discussions are critical to also refine, as you'll see on the next slide, our list of organizations that we included in the network for each area. We conducted a web-based survey of all organizations to measure organizational and relational characteristics and to understand the connections among the organizations. And finally, we collected secondary data from the Ryan White Careware system, as well as testing data from the Florida Department of Health for testing outcomes. An important note is that we're studying HIV not only because of the population health significance, as described earlier, but also because outcome data at the organizational and eventually, potentially at the community level is available through public health surveillance systems. We actually were able to collect both self-report and secondary data from the Florida Department of Health on both continuous care and linkage to care outcomes, though not presented in today's presentation. So a critical step in our methods was to identify the organizations in each regional system of care. We did not study any a priori coalition or have at hand a list of organizations that made up our sample. Instead, we followed an iterative process to develop and refine this list of organizations for each area. Our partners had a critical role by first helping us craft our definition of an included organization, which you see here, organizations that contribute to the key outcomes of early detection, linkage to care, and continuous care. Then our partners assisted by drafting the initial list of organizations that met that definition. Subsequent key steps were to conduct these interviews with the staff in each region and having them validate our list of organizations to suggest those that they did not agree with and to suggest additional organizations to be added to the list. Also, discussions with state-level stakeholders, which were the Florida Department of Health and the Community Health Center Association. And then final review and confirmation by the community partner. So I'll turn it over to Dr. Bevc to take us through the rest of the methodology and some results.
All right. Thank you, Dr. Porterfield. So once we had our list of organizations, that allowed us to create a roster, which we input into the partner tool. So for those of you who are not already familiar with the partner tool, you'll get a chance to hear from its creator, Danielle Varda, a little bit later during our commentary. It's a online survey tool created was originally funded by the Robert Wood Johnson Foundation to gather data, social network data on organizations. So it gathers data at both the organization level as well as the relational level. It was intended for public health departments and coalitions and collaboratives to be able to collect data to assist with charting their progress and how they're working together and strengthening, and has since been used by more than, Danielle will have the actual number, but it's been used by over 500 collaboratives at this point. So we used it to measure four regional areas for our project here. So with our research aims in mind, we're looking at both the organizational and relational data to be able to consider the variation of the numbers and types of ties between the organizations, both including the testing organizations as well as those that provide HIV clinical care, the relationship between those, as well as the patterns of their relational ties. So for those organizations that may be providing fewer services or those that offer more specialized services, how more or less likely are they to then need to refer clients to those for care to more than other more comprehensive providers? And so we wanted to be able to look at potential gaps in the system and identify and explain what we might be seeing within each of these regional systems of care. And then also, this allows us to essentially assess for a subset of organizations. So we can look at those organizations that provide HIV clinical care or those that provide testing services to look at which organizational or relational measures are therefore associated with either improved continuous care or linkage to care. So as we consider the spectrum of care and engagement across the continuum, what mechanisms are then able to allow clients and patients to maintain and move across that continuum rather than fall off the continuum. So our results today that we're sharing, we're going to start with our descriptives of each of our 4 areas. And in the time that we have, we start with our quick summary across all 4 areas. You can see the overall population. They're quite relatively large. We have the total number of organizations in each of our 4 networks, and then our number of organizations that we surveyed. And the difference here is because when we were asking our interviewees for contact information and then following up with those organizations and asking for individual points of contact, even though the organizations fit the definition that they have provided, identifying a single point of contact to serve as a proxy for that organization to be able to respond to the survey was proved to be difficult or challenging, or we just simply couldn't find someone who that they could identify. So in many cases, this would be a hospital system where they would receive a call from a nurse or a caseworker where there wasn't a single liaison who they were in contact with. And so that explains some of the discrepancy between the network and the number that are surveyed. So immediately our response rate drops, but the response rate that we see here is based off the number that we surveyed. So the N of 19 and the response rate of 56% is based off the surveyed number of 34. So of those that we received responses from, we have the breakdown of those that provided testing services, linkage services, and HIV medical care to align to those different steps along the continuum of care. So you can see there, and those categories are not mutually exclusive. But it gives you a breakdown to show that for some of these categories, there are not a lot of providers. And even though there may be 81 organizations within a network in Area B, when we start to drill down to look at who is providing medical care, HIV medical care within that area, the number of actual providers is very low. So even though we were able to receive surveys from 19 organizations, only 7 of them reported providing medical care, HIV medical care. So already when we start to look at, who is actually able to provide care, we immediately start to see that there are some, the availability of care may be very limited within these areas. So this also provides a breakdown of who exactly is in these areas. And this is independent of response rate. So this takes that total number. So if we go back real quick to look at some of these larger numbers. So this is the 69, the 81, the 44, and the 77. And this shows that distribution across these different types. So community-based organizations, health departments, faith-based, HIV clinics, private providers, which include the ID specialists and primary care, who are included as HIV medical care providers. So Leah, that answers your question about the HIV medical care providers that you just asked. So if they responded to the survey, they were included as HIV medical care providers and are indicated here as the dark purple in here. So you can see they're represented, the variation across all 4 areas in terms of the composition. And what we highlighted in the upper right there is that mental health providers we only found those in 2 of the 4 areas in terms of being included. So that was a little bit of variation. That even though mental health was considered to be one of those essential support services, that really did seem to make a difference in terms of engaging clients and maintaining engagement in care, the availability of mental health providers within the system of care seemed to be limited in some areas. So continuing to describe who these providers were across these 4 areas, this average size of the organization, they saw approximately 450 patients, and these were HIV individuals living with HIV/AIDS. So some of them did not see patients, and some of them saw up to 3,000 patients. But on average, they saw about 450. So on average, these are very large providers. They also offer a range of services. So 2/3 of them are offering testing services. 46% of them are reported offering linkage services. And the ranges here are provided for the 4 areas. So the minimum is the lowest area, and the maximum is the highest area. So it's across the 4 areas that we have. And then the 42% that reported providing HIV medical services. And then we include this 4th category of 60% that provide one or more of what we categorize as evidence-based or informed programs or activities that are shown to increase linkage and continuous care. And so those include services such as case management, peer navigation, transportation, the co-location of services, bilingual or bicultural healthcare teams, as well as providing reminder calls. So if they offered any one or more of those services or activities, then that they are included within that category. We also asked about their funding levels and where they received funding from, because part of our research aims include that variation in terms of where their funding comes from. And whether that may be a potential driver in terms of patient care and engagement with other providers as well. And so on average, providers reported receiving funding from an average of 4 different sources. And we had a list of 19 different sources. And so it ranged from 1 to 15. And so if you can think of being an organization having to respond to 15 different sources, it's a lot of paperwork to have to complete, but on average they had 4. And 2/3 of our respondents reported that they did receive some type of Ryan White funding, and so that includes all 4 parts, so Part A, Part B, Part C, and Part D. So they do, there is a bit of a bias towards Ryan White providers in our sample here. But since we know that these organizations are not operating within a vacuum, we also want to look at their reported relationships. And so considering the relational data that we collected within Partner, most frequently, of the 9 relational measures that we gathered, the most frequent relationship that was reported was client referrals. And so organizations referred clients for a range of services, and on average, they referred clients to 13 other providers. And so, across the 4 areas, there was a range. In this case, it's out degree centrality, varied from 1 to 53. We also asked about the routine frequency of interaction, and they reported about once a month. So interaction is not too frequent, but it's not quarterly. So we do know that it's routine at this point. One other measure that we wanted to report here also is the high level of mission congruence. So the extent to which the goals of the organizations align with one another. And across all 4 areas, there's a very high level of mission congruence, where overwhelmingly organizations reported that there was a great deal of mission congruence. And so this also goes along with our definition for our boundary inclusion of our network as well. So it goes to organizations that are providing the services that they're providing. And with any system of care and working with others, we wanted to also here report our top facilitators and barriers. And so along with the mission congruence, not surprisingly, one of the top facilitators was common goals. So organizations working together because they share those common goals, but also because they really share a common interest in serving their clients and having a very patient-centered focus and wanting to provide what's best for their clients. In terms of barriers, the top 2 reported barriers, not surprisingly, were limited staffing and resources, both in the number of availability as well as time. That included time and funding. And then also the second barrier was perceived competition for funding resources and deliverables. And so even though they may be working together, they also are perceiving each other as potential competitors within a similar space. And so those were potential barriers across all 4 systems. So what exactly do these systems look like? And so we can see all 4 of these regional systems of care. We highlight the gray small dots that you have, these tiny little ones here, are those non-respondents. The blue ones are respondents that do not provide linkage services, and the red nodes are those that provide linkage services. The size of the nodes here are based on the out degree centrality, so it's weighted off the number of connections that they reported having with others. And then we just use a traditional graph theoretic projection. So the way that the dots are laid out here that we see, those that have more connections are pulled more towards the middle of the graph, and those that have less connections are pushed towards the outside of the graph. So we're not looking at these in terms of geography. So the placement is not dependent upon where they are within their region, but it's based upon where they are within the social network. So again, those that are more central to the network and more connected to one another may be pulled more towards the center, and those that have less connections are going to be pushed more towards the outside of the network. So if we drill down and sort of look at where these critical linkages are, and to focus on the the specific types of relationships among these organizations. So we wanted to focus here on, overall within, this is focusing on one network. So going back, we have 4 networks, and we're going to drill in. I'm going to highlight this, pull the arrow. We're going to look here at this organization up here. And on the next page, this just looks at the critical linkages to care and the relationships that we have that have in terms of referrals for service from providers that refer for linkage services to those that provide linkage services. So we go from all possible ties, which is what we saw on the last page, to filtering down across those 9 types of relationships to look at just those that are referring clients and those that are referring clients for linkage services. And so, again, lines representing referrals for linkage services, the arrows for directionality. Red is if they refer for those, and then red outlines if they refer, and then solid red if they provide. And what we see is that you go from 308 connections down to just 6 connections. So these are 6 connections of referrals for linkage services. So organizations that reported that they refer clients for linkage services to other providers that then offer those services. So we can see that even though there are many different connections across that system, when across that spectrum of care, moving clients from one step to the next, from testing to linkage, and then if we look at the next step from linkage to continuous care for HIV medical care, referrals for service, which also include outpatient ambulatory medical care, OAMC services. Those number of connections also are very few. So again, we go from 308 connections down to 21 connections. So the number of referrals between organizations, those lines become very critical between those organizations. And so for the sake of time, we're going to go ahead and we can come back to this. So if you have questions, please go ahead and type them into the chat box. They'll go ahead and flag those questions for us, so we can come back to those. And we can also jump back to these slides too as well if you have additional questions. But what these really highlight is that when we think about a regional system of care and how organizations are working together, when we have when we look at the continuum of care, and you drill down on that continuum to where connections are and what it means to move from one part of the continuum to the next, and that connection from one provider to the other, what does that mean? And when we drill down into that, you look at how fragile and how potentially limited those connections might be. And so as our research in progress at this point shows, we have a high average of provider connections. So providers are working with a lot of organizations, especially given the number and diversity of organizations in each area. But there's a relatively low number of client referrals for those linkage to care and continuous care compared to all other interactions. And so there's really this potential this need to increase referrals for service and avoid what we saw on one of the previous slides of these network isolates, where there's a provider who is available to serve clients who may not be receiving referrals. And whether that's an artifact of missing data that we have as limitation of our sampling right with our network here, or whether it is in fact a true isolate where providers are not referring clients to another provider, that's a question. So focusing our research aim 1 focuses on this importance of critical linkages. Our analyses right now, which we are teasing you for our forthcoming presentation, the Academy Health DHSSR interest group meeting later this summer, where we will reveal these results to you, where we're looking at these, at how providers are working together, looking at these services, drilling down into these questions, focusing on this subset of client referrals, looking at specific service providers, looking at funding, and taking into consideration some of the, working through some of the limitations that we have. So general to all systems-based research, we're obviously, as I mentioned, with mission congruence, we have our definitions and we have our inclusion criteria, and that, as we've seen with the high commonality of goals, that has implications into which organizations we've included in our system. And so we have, to the best of our knowledge, developed a comprehensive and valid list of organizations meeting this criteria. Another limitation is that we have, for this project, we saw the timeline, and part of our response rate issues is that our project was with the times that we had certain lags in terms of that led to disruptions in engagement with our partners. So we could have lots of conversations, and then we'd have periods of, well, we're waiting to hear on things. And then another piece to this is that several of our areas were interrupted and affected during our study period by two major disasters. We were hit by Hurricane Matthew, but even prior to that, one of our study areas was affected by the Pulse shooting. And so trying to collect data during critical periods of time where you have a community that's been dramatically affected and disrupted, coming in 2 weeks later saying, hey, complete a survey, there's things to be respectful of. So we have low response rates to the organizational survey, and then also being able to tie this and validate this with some of the Ryan White outcome data. We're working with that as well. And so I'd like to invite Dr. Porterfield to jump back in here, and if there's anything that I might have missed on this slide.
No, thank you. Thank you, Dr. Bevc. Let's keep rolling. Just one last slide in terms of implications. So obviously in this project we are still in our data analysis phase, but we can nevertheless discuss some potential implications. Clearly, HIV/AIDS service delivery networks are complex with numerous types of organizations that contribute to the outcomes of interest. We feel our methods for developing the sample in particular worked well, and they were absolutely necessary given the complexity of these systems. But of course, the iterative nature and the need for involvement of our key community partners were notable. Definitely, we believe that network methods have a huge potential for studying these complex systems. However, in this particular project, one of the challenges, as Dr. Bevc was sharing, was the response rate. So we strongly suspect that perceived participation in a system of care is an important driver of that response rate, as evidenced by the fact that overall, most of the organizations, 66% of those that responded to the survey were Ryan White funded. Whereas that we don't have that number at hand, but of course that's not the statistic for the overall sample. So more common in these types of studies is to study an existing coalition or organizations with an acknowledged structure around them. And so clearly this was a challenge inherent in our goal to have stakeholders help us define the system and include the breadth of organizations, however, including those that may not have considered themselves part of this network. Finally, these are early descriptive results, though we do also have the feedback received from our area stakeholders when we presented these descriptive findings, and we feel they absolutely highlight the areas for beginning to highlight the areas for system improvement, including focusing on those necessary ties for referrals to achieve the goals of linkage and continuous care. So as Dr. Bevc suggested, our next opportunity to present our findings is at the June Academy Health DHSSR interest group. I also want to be sure you see that we have our contact information here, and we welcome your comments or input, and as our project findings evolve, we'd be happy to share them, so please do contact us. And of course, we're planning additional opportunities for dissemination, including manuscripts as well as a policy brief for policymakers and practitioners. And of course, our project abstract does live on the Systems for Action, or the PHSSR National Coordinating Center website, and our updates will be posted there as available. So let me turn it back over to Dr. Ingram as our moderator, and we thank everyone for your time today. We'll move on now to our commentators.
Thanks so much. So we have two folks from the representatives from the research and practice community who have agreed to provide commentary for today's presentation, Dr. Danielle Varda and Yasmin Andre. Danielle, have you managed to connect yet? Okay, let's start with Yasmin Andre. So Yasmin Andre, she graduated from the University of Central Florida in 2012 with a Bachelor of Science in Health Service Administration, and she's currently a graduate student of the Executive Health Services Administration program at UCF. She has over 5 years of nonprofit and grants administration experience in the field of public health. She currently serves as the Clinical Quality Manager for the Ryan White Part B program at Heart of Florida United Way, and she's responsible for ensuring the delivery of quality continuum of care through the development and routine maintenance of the quality management program for Area 7 in Florida. So Yasmin, could you start us off?
Sure. Thank you so much. So I was definitely very intrigued by some of the findings that were presented in this presentation. I think it's very interesting to see how these findings might relate to those careware outcomes that were discussed earlier. And I'm also interested in seeing how we can continue to look for opportunities to incorporate some of these findings into our system, especially as we move further towards aligning all of our Ryan White parts in our service area, combining our planning bodies and things of that nature.
All right. Dr. Varda, are you available?
This is Danielle.
You there?
I am. Can you all not hear me?
We can now.
Okay.
So go ahead and knock it out of the ballpark.
All right.
Okay. This is Danielle. My apologies for not being able to be on sooner. I'm on trying to figure. Comment on work that Christine and Deborah have been doing and leading this project has been really phenomenal and really kind of groundbreaking in the way people are thinking about networks and thinking about systems. And I think that when I first heard from them that they were interested in studying kind of a system and using a network approach, I realized how really brave that was in the sense of the data collection aspect of it. As both of them have mentioned, it's difficult to collect data from systems, and I want to kind of distinguish that from what Deborah already mentioned, which was the difference between a network, let's say in a community that already has a bounded set of people that we know who are members of that network. And so when now what Deborah and Christine have been working on is what a lot of people are starting to think about is, how do we start thinking about these complex relationships as bigger than that bounded group of partners? And how do we even identify them, and how do we even get our kind of hands around who they are and how they interact? So by setting out kind of even on that journey, they've opened the door a little bit for the kinds of methods that we can use. And so I know they mentioned a little bit about the limitations of that, but this is good news for those of us who are interested in studying this kind of stuff, because we can learn lessons from them and learn lessons on how they approached the people who they wanted to participate in the study, how they approached asking those questions, and even how they're interpreting the responses. And so I thought the analysis that Christine presented around looking at the kind of overall number of connections that people have and then saying, hold on, let's break that down into some maybe more meaningful connections, was really a great lesson learned, maybe even from how we think about how we collect the data. So something I think a lot about is, are we trying to collect a lot of data just to collect data on how people interact? What if we broke that down and only collected data on the most important or the most informational connections? And could that make getting information from a lot of people in a complex system more attainable? So I think there's a lot of lessons in the kind of work that they've done here. I know that when we first talked about this was something that came up quite a bit, was how do you study a system and how is that kind of an expansion of a network? I think this is a great area for them to look at this. The connection between providers, referrals, patients, community is something that we're all talking about in the health and public health world today. And so the learning that they are also bringing to us as the results has been something that I think is also really moving the field forward and helping us understand the provider-patient, provider-community referrals. They call them the critical linkages. And I think that we need to know more about that. Those dyadic relationships are still kind of an unknown for a lot of us in the field. And for us to be able to have data and have information that can help not just move research forward, but to really move practice forward and really inform people who want to do that work on the ground. This is really kind of important work. Really, not kind of, it's really important work for us to keep thinking about, so that we can continue to think about the ways that data can inform that practice in communities and for patients and for people really moving through healthcare systems. So I've been really excited about the work that they're doing. I'm really excited to be a partner and able to think about some of these issues with them. But really their leadership in this area has been really critical, I think, for moving and being a good model for studying systems in this complex way forward. So thanks for the opportunity just to be able to say that and to learn from you all on this call.
Danielle and Yasmin, thank you for the thoughtful feedback. We've got time for questions. We've got a few questions that are in the kind of in the queue already. So our first question was from Leah Slitsky, who asked, are the HIV medical care providers infectious disease specialists or primary care providers as well?
Hi, Leah. Yeah, so to answer your question, so if we jump back to the slide of looking at the overall number of providers, so there's HIV medical care providers. So in that bottom category there, so these providers here, if on our next slide, if they had responded, so they would probably fit this category of private providers. So if they had responded to the partner survey and had self-reported that they provided that HIV medical care, either as a primary or as a specialty, then they were included in that category. So yes.
All right, great. Next question we've got in the queue is essentially it's kind of related to slides 25 through 27. It asks, can you provide more information about the types of relationships among organizations or how the linkages were measured? So kind of more about how you specifically measured what was going on here.
Sure. This question comes from Maruna. So I'm glad to see Maruna. So I'm actually going to go to slide 18. So the questions on the relationships that we measured come directly out of the partner tool. So we have 9 relational measures that we captured from this, and so we use those measures directly from what is currently in the tool, and so it captures relationships related to collaborating on funding opportunities, coordinating outreach and communication, establishing formal agreements with each other, participating in meetings or groups, participating in training and education, providing and receiving resources, providing and receiving client referrals for services, and sharing information and data. So these are binary relationships that they check. So it is a check all that apply for those categories, and then for the frequency of interaction that we've reported, how frequently are organizations working together, that was an ordinal scale that they had responded to, ranging from never or only on issues unrelated to HIV care all the way to every day. And so that went from every day, every week, once a month, once a quarter, once a year or less, to never or unrelated to HIV care. And so for the linkages that we saw on slides 26, so here we extracted those from the combination of if they responded to the linkage, the referral question, and the organizational reported data of do you provide the service, and did you refer the service? So under our organizational questions, we asked them to identify from a list of 27 services, of those 27 services, which ones they offer, and then we also asked them of those 27 services, which ones they refer which ones they refer clients for. So hopefully that answers your question.
Great. Looks like we've got another question in the queue. Gay Kohler Sides asks, do the areas that have more connections have a higher percentage of people with suppressed viral loads?
So that's a really good question, and that is a question we would love to be able to answer. So there's two parts to that. One is that we are focusing, the focus of our research is on the early portion of the spectrum. So we're focusing on that initial detection, linkage to care, and then engagement and continuous care. So the data that we have in terms of outcome data for where they are in terms of their care, the outcome data we have is related to testing data as well as their services that they've received. So whether they've been able to maintain engagement and receive continuous care. So if they've been able to see their provider within the 6 month period of time. So we don't have data on suppressed viral loads. So the next step for our future work that we would love to be able to do would be able to then expand this to be able to then take this work and look at that and say, okay, so moving to the larger system of care with a higher response rate, with additional data, more outcome data to say, looking at clients, looking at their connections, do then those that receive care, do they then achieve viral suppression based off the level of care that they receive? So, and I will also let Dr. Porterfield jump in on this as well, too.
Yeah, I would love to add to that answer to point out something really important in this question that highlights where this project is, but also where eventually this research can go. And we mentioned it briefly at the beginning. We have some organizational level outcomes, and we'll look at characteristics of organizations in relation to the others. So that's bringing the network methodology to this project, but only being able to study outcomes at the organizational level. But also I see in this question, again, where we would love this research to go, which is what about measurement at the system level, and then measurement of outcomes at the system level. And again, this is where we feel like this is not only an important clinical public health topic, but also a great one to use this method to study, because with public health surveillance data, there is the possibility for that area level outcome. And so if we had, a huge sample, you could study system characteristics with the outcome at the community or the area level. And Of course, that's not possible for just about all of diseases that we're interested in, and it makes HIV just a really important topic and then also very relevant for this kind of methodology. So that's a great question. Thank you, Gay. Sorry we can't answer it, but it's a very good question.
All right, we've got one more question in the queue here. Ozma Vikar asks, is there any organization collecting data of sex workers with HIV?
So I'm actually going to see if we might be able to ask Yasmin this question, because I think that might be a question that's collected within by providers for careware and might be part of the Ryan White reporting requirements.
As far as I know, that is not information that our providers are collecting. I know that is definitely information that our testers are collecting, and I'm not sure if that's something that I can check in with some of our providers about that information.
For this project, so we don't have that for this project, but I am sure that data is out there somewhere.
All right, looks like we are coming to the end of our webinar. Still have time for one more question if anyone wants to type one into the chat box. Great. So, here's a list of our upcoming webinars. The next, kind of the month of early May, one on the implementation and diffusion of the New York City macroscope electronic health record surveillance system, and one on cross-jurisdictional resource sharing and the scope and quality of public health services. We've got an archive of our webinar at the kind of URL up at the top of your screen. Thanks again for participating in today's event. This is our contact information. For more information about the webinars, you can contact Ann Kelly, our project manager, at ann.kelly@uky.edu. We'd like to acknowledge the support from the Robert Johnson Foundation and our partners at the University of Kentucky. Thank you so much.